Tazama Monday Special Town Hall tukiwa katika kaunti ya Isiolo, ukumbi wa kanisa Katoliki la Saint Eusebius. Tunazidi tu kupokea maswali kutoka kwa wananchi, pia kutoka kwa mtandao wa Twitter kuhusiana na mdahalo wetu wa hii leo kuhusu ni vipi serikali kuu na serikali ya kaunti wataweza kuafikia yale malengo yao katika kutekeleza ajenda kuu ya afya kwa wote, pia jukumu la KEMSA katika ajenda hiyo. Lakini kuna swali hapa kutoka kwa Abdikadir Ali Abdi Kunradhi, ambaye anauliza swali kuhusia kwa maafisa wa KEMSA.
Halo, majina yangu ni Ali Abdi, ni mkazi wa Isiolo County. Ningependa kuuliza KEMSA, hivi karibuni mlituahidi ya kwamba mtaleta service karibu na watu wa Northern Frontier District, ambaye mtaweka go down zenu hapa Isiolo ili watu wa Marsabit, Wajia, Mandera wawe wanahudumiwa kwa urahisi. Je, bado hiyo mpango iko ama
huo mpango upo?
Good, asante sana Abdi. We have been discussing with the governor, and the governor has been gracious enough to allocate us some land. The process of allocation of the land is ongoing. What we want to do is to leverage on the county of Isiolo with the emerging threats of Isiolo becoming a business hub and becoming a center that is serving the northeastern region and also part of central region, talking about Laikipia, including Meru, and other counties surrounding this particular county. So we shall be constructing a warehouse, and the warehouse is intended to serve over and above the northeastern region, including the places like Turkana County. So we have had discussion with the governor and it's ongoing, and we shall be able to construct the warehouse pretty soon.
Na kwa gavana sasa, Daktari Mohamed Kuti, kulikuwa na yale maswali ambayo yalikuwa yametumwa kutoka mtandao wa Twitter kuhusiana na kupandishwa daraja kwa wahudumu wa afya, na pia kuhusiana na kama hakuna kituo cha afya katika wodi ya Oldonyiro.
Nikianza na hilo swali la pili, wewe ulikuwa wodi ya Oldonyiro katika maonyesho tuliona hapo awali. Kwa hivyo umeona iko Kipsing Health Center ambaye ni health center ya kipekee. It's a demonstration health center. Obviously iko na challenges zake, lakini umeona madawa ziko, ambulance ziko, ingawa imevunjika, na ilipovunjika ile mbele tumeweza kuleta mpili ya. Kuna pia hospitali ya Oldonyiro ambaye iko na maternity. Nakumbuka nilijenga hiyo maternity nikiwa mbunge kutumia pesa ya CDF. Kwa hivyo si kweli kwamba, na hiyo ndio yale nilikuwa nikisema kwamba mambo mengi ya afya ni ya kichwa. There is mistrust, there is lack of trust because of lack of service over a long period, and not 5 years, more than even 10, 15, 20 years. We are working very hard to win trust, public trust. So the public health service must work very hard to win public trust. You may see that the improvement done could be this much, but the public appreciation is this much because of a long-standing lack of trust. So we will work on this. We will work on this, and we want to prove ourselves that through devolution, health service, public health service will work. But it will take time for the public to appreciate because of long-standing mistrust. And people, as I said, will rather wake up, sell whatever they have to go to a private facility in Isiolo than to be referred to Kerwa. This line is more trusted than the public line, which we are trying to work very hard to bring up. And we will bring up, and this trust we will win. Coming to issues of promotion, it is true that for a long time there has not been promotion. But the issue of promotion is not that actually it's uniform. There has been a preferential treatment in this because of the messy situation our payroll has been in. We have now embarked, and we have actually now cleansed our payroll, and we have also set up a Human Resource Advisory Committee comprising of all the chief officers, who will then come together, discuss issues of discipline, issues of promotion. And so we know there has been people who have been promoted, like 5 job groups, while some have not been promoted for 10, 15 years. These disparities are there, and it's real, and we are working to iron out all this so that those who have not been promoted, there is actually a promotion that has been passed but has not been put in the budget, which we want to put in this supplementary which is coming. So we're working on that also.
Kwa hivyo inaonekana kwa wahudumu wa afya ambao walikuwa wanangojea kupandishwa daraja, itabidi wangoje kidogo tu ili jambo hilo liweze kutekelezwa. Hebu tupate swali lingine hapa kutoka kwa watu wanaoishi na ulemavu kuhusiana na ni vipi ambavyo mpango huu wa huduma ya afya kwa wote utaweza kuwafikia.
Kwa majina naitwa Mohamed Abdullahi. Mimi ndio polio ambassador Isiolo. Langu ni ombi kwa serikali ya county na KEMSA, kwa sababu mlisema mtafikisha huduma mpaka mashinani. Sisi jamii ya walemavu tunapitia shida. Mtu mlemavu kwenda kupata dawa, kununua na mfuko yake inakuwa ni ngumu. Ombi langu kwa serikali ya county ya Isiolo na KEMSA, njia gani mnaweza kujitokeza ili mtu mlemavu anapokuwa mgonjwa aweze kupata dawa kwa urahisi, kwa sababu mtu mlemavu pitia shida sana.
Nadhani hilo swali ni kwako Governor.
Ni kweli kwamba walemavu wako na changamoto kubwa kuweza kupata huduma, hata kuingia kwa hospitali. Saa nyingine hata the facilities are not disabled friendly, you know, like they can't even come up like here, you know. So there are a lot of just such challenges. We are mainstreaming disability. We want to be the county to be benchmarked as the county that advocates the most for the disabled. Just last weekend, we had a very big event called the Desert Wheel Race, where almost 5 governors and 2 cabinet secretaries and several dignitaries joined the disabled in Isiolo and also from 14 other counties to be able to highlight the plight of the disabled in Kenya. And we are in the process of negotiating for a corrective hospital where disabled children like clubfoot and spinal problems could be catered for here in Isiolo. We also are putting up a disabled academy, sports academy, because we want to mainstream the disabled in Isiolo and also be benchmarked actually as the most disability-friendly county. So in the same tone, we want to assure Medize and other disabled that we will actually have them in the midst of ourselves in terms of contracts, in terms of all considerations, including medical care.
Naam, Dr. Kuti, nadhani leo ndio siku ambayo wengi wanataka kupata majibu kutoka kwako, manake pia ulikuwa mmoja wa wale ambao waliweza kuwa katika ujumbe ulioelekea Cuba kabla wale madaktari kuletwa humu nchini, na hili swali nadhani pia ni lako.
Mimi naitwa Jerry Ranji, mimi ni mkaaji wa Isiolo. Swali langu ni kuhusu wa Cuban doctors. Ningependa kujua how effective are they and the mode of communication ile wanatumia kwa watu wetu wa Isiolo.
Go ahead.
Well, I know that the Cuban doctors have added value to our healthcare kwa sababu mmoja ni family physician na mwingine ni surgeon. Yule surgeon, when I checked his data, the last, which is about a few days ago, has done more than, is it 500 operations, 500 to 600 operations, major operations, and seen close to 2,000 patients. The same figure goes for the family physician. I don't know the exact figures, but over 1,000 patients in the period that they've been here, which is about less than 6 months. Also, they have really integrated, and we, in improving our referral system, you have heard that operations are now happening in Garbatula, the theaters in Garbatula, and we have posted a doctor there. And also in Merti, and we have sent a local doctor there. This surgeon is going to visit these two facilities regularly. The doctors in Garbatula and the doctors in Merti will prepare a list for cold surgical cases. Emergencies will be referred using ambulance, but cold cases will be kept at Garbatula and will be kept at Merti, so that these Cuban surgeons can now go and visit and do those operations at Garbatula and at Merti, because now we have for the first time operationalized Merti and Garbatula. So they will not only work here in Isiolo, they will therefore also move to the sub-counties, and that is already happening because we have already opened up and operationalized these two sub-county hospitals.
Before I hand over back to you, Joe, kuna swali ambalo lilikuwa limeulizwa na Abdi kuwa why does KEMSA take a lot of time to deliver medicine?
I must admit, KEMSA does not take a lot of time to deliver medicines. So it depends on when the order was placed and whether the order was rationally placed. And if it's rationally placed, we will pick the order and deliver as soon as possible.
What do you mean rationally placed? That's
when you talk about rational ordering, is that we have a system called Logistics Management Information System. So, and in the logistics management system, we do have a tool, and that tool is where the counties are required to place their orders. If you download a node form, then it's very difficult for KEMSA to do data quality analysis when it comes to a KEMSA warehouse and to process that particular order. So we have to revert the order back to the county so that it's placed in the right form to allow us to be in a position to pick the order and process as fast as we can. But yes, we normally take a maximum of 7 days upon receipt of an order by a county.
Joe, sasa nitakupatia usukani ili uweze kumalizia.
All right, thank you very much. Ladies and gentlemen, Isiolo is one of the 4 counties that have been picked for the pilot phase of universal health coverage, of course, together with Kisumu, Nyeri, and Machakos. I want to get an assessment from each one of you about how ready we are to embrace this, because there's a roadmap that was outlined about registering people in NHIF, different things under that, disabled, vulnerable people on fringes of society, as it were, assessing readiness and that sort of thing, and getting to a point where now we are ready to roll this, at least in the 4 counties, as we start to do certain things in the remaining 43. From where each one of you sits, and I'll start with you, Valentine, do you think that Isiolo, or indeed the country, from your conversations with the people you work with, is ready for this? What needs to be in place anyways, according to you?
Universal health care is the right of every Kenyan. And we have a lot of gaps in Isiolo, just like the governor also spoke on. We have a lot of gaps, and we need to address these gaps. NHIF is one of the things that the local Mwananchi has embraced, because I think I can say almost 60–70% of the people will have NHIF because of the health challenges that nowadays we go through. Though maybe because of the pastoralistic nature of where we are, it is also a challenge, because most of the people may not understand NHIF, especially in the interior. We have a few challenges because of the health centers, especially the dispensaries in the interiors. As you've heard, our referral system also has issues, because even as now, we still do not have a blood bank, and that is what also raises our maternal rates. The death rates are still high. So I think if you're going to be able to work and see how we can be able to seal the gaps in the health sector, we are ready for the universal health care. But we cannot be ready if we are not going to be able to address the gaps that we have.
Dr. Abubakar, where are we in that, on that roadmap, according to you? How are we doing with the registration, for example?
Okay. Thank you, Joe. First of all, I would like to say that UHC is a journey. So it's a continuous process. It's not a one-time event. Having said that, what have we done? So we've started by thinking from a position where if UHC is announced today, will the people get the service they need? So we started by addressing what are the problems on ground. So number one, the issue about commodities. So we have put our ordering system in order. We have brought on board KEMSA and MEDS to supplement the orders. We have done forecasting and quantification just to get an estimate, a good estimate and projection of the increase in numbers that will be brought about by the universal health coverage. Number two is strengthening the referral system. As our governor said, the idea is to have as many people as possible to be addressed at the level of primary health care, which is the community health strategy, the level 1 community level, level 2 dispensary and health centers. And so, and having a referral system across the line. And that is where now we have repaired the ambulances to help in moving of the patient, put structures in place on how people can move from one point to the other, not going directly and starting from level 4. You have to start from the dispensary where you are, if NHIF is used, then you are capitated in that dispensary. There's the issue of human resource. Our human resource capacity is one of the lowest. We have 3.1 healthcare worker against every 10,000 population. So, and based on that, we've also been looking at ways of improving the healthcare workers. Earlier this year, we recruited about 42 nurses to fill the gap, and that we have felt the difference, because initially each health center, each dispensary had only one nurse, but now currently we have at least 2. And soon, in fact, within the course of the week, we'll also advertise a number of positions for healthcare workers, just to fill the gaps that are there, and also to operationalize a number of health facilities that are yet to be operationalized, which again, feeds into the bigger UHC agenda, spreading the facilities to improve accessibility. Isiolo is one of the counties that has the highest, distance from one facility to the other. Reaching one facility, you take an average of 49 kilometers. It's one of the worst, against an average of 9 kilometers countrywide.
And I imagine that is one of the reasons why it was picked as part of the pilot, because there are lessons that will come out of that. But let's come to you from KEMSA perspective. Where are we in that journey in terms of being all set, as it were, for universal health coverage?
Thank you, Joe. Clearly stated. The fact is a journey, and what you have done is that we have identified some of the commodities that we need to add to our portfolio of commodities, and especially so commodities that are targeting primary health care, especially point-of-care diagnostic devices for screening of, say, malaria, screening of diabetes, hypertension, and all that. So we have already put them in our procurement process, and we're in the process of procuring them. And then we have already brought on board other commodities that are targeting primary health care. We have identified strategic partners to fill the gap. As my colleague has said, METH is not our competitors, they complement us. So we'll be working with METH pretty soon. We'll be working with Kenyatta National Hospital to ensure that whatever framework contracts that Kenyatta National Hospital, being a government agency, has entered to, we can also leverage on that. And then we've been working very closely with the Council of Governors through the County Pharmacists Forum. Lucky enough, the chairman of the County Pharmacists Forum resides in Isiolo County. That's Dr. Clever Kimathi, who has been very, very effective in identifying new commodities that the counties require to be able to meet their needs. So for us, most important is to ensure we meet the commodities needs of universal health coverage, and we have the capacity, we have the will, and we are ready to roll out universal health coverage.
Bwana Governor, as we almost bring this to a close, we started with the question of money. One of your governor friends told me that as things stand, we really don't know how much it's going to cost to make this happen, and that is why perhaps we are trying. Where do you see us going in terms of being able to? Because one of the ideas about universal healthcare is to shield people from the out-of-pocket, and there's something that's called financial catastrophes that people would deal with when they get too sick and that sort of thing, and they have to pay for themselves. Where do you see that lying in this whole conversation that we have? Where is this money going to come from?
Well, healthcare is very expensive. And when we now take the responsibility from Mwananchi, that now Mwananchi can walk into a health facility, get quality health care, and walk out without paying. And that's the target of UHC. The debate is shifting. I am on the highest committee, and the debate is becoming clear, and this has been said by the president, and there is this committee of minimum package that has been set up. Minimum benefit package,
essential basic benefit
and
package.
It's becoming more and more clear that we need to strengthen primary health care so that as much as possible we focus on prevention. That means level 1 community health service, level 2 dispensaries, and level 3 health centers, so that 80 or so % could actually be taken care of at this level. So there is a lot of focus on strengthening these 3, while at the same time also making sure that the referral facility that takes care of the curative, that's the level 5 and level 6 national hospital, are also enhanced. Some of those are already enhanced, like Kenyatta National Hospital, which still also needs further enhancement. So the focus now is to make sure that the counties strengthen their community health service and dispensaries and health centers. Now there will therefore be funds either through NHIF or directly from Ministry of Health to supplement the budget from the current, like now we are about 30%. Possibility are that we will get almost a similar amount that we already have, so that our percentage goes up. This is through support from World Bank for this pilot, but there is a lot of interest from bilateral donors and other players, because it is known that universal healthcare is now the debate the world is heading towards, and therefore the government is negotiating at various levels, I'm aware, to be able to fund universal healthcare, but with a more focus towards primary healthcare. Because
primary healthcare, by that you mean
community health service level 1.
Sure people don't get sick in the first place.
As much as possible, you strengthen community health volunteers. You, like us now, we are in discussion with some organization that has put technology on top of the community health volunteers. The volunteer
Maybe
now,
you need to talk about that, because I saw some stories that you had been summoned to the Senate to explain the deal that you have with this organization. It's called Living Goods Limited. What's that deal? Because
either Living Goods or AMREF or another one called Farm Access are being utilized by counties to...
What's that arrangement? Because some people in Isiolo have been complaining about it.
Of course, there is... we have been talking about resource and the fact that the resources are not there. So Living Goods is coming with... its focus is to strengthen the capacity of counties to strengthen their community health service, which means they will partner with us initially on a 50-50 basis to engage volunteers. We now have a less than 20% functioning community health service. Even the ones who have been hired or maybe getting stipend are no longer getting, and they are so demotivated. So we are going to increase to almost 1,000 across the county, and then they will be given a smartphone by this organization, and this smartphone is able to prompt questions and also has a reminder for the area covered by this volunteer. Like, let's say it will tell you, oh, house number X, the kid is due for immunization, or house number Y, the mama is needs to go for antenatal clinic. Today you are supposed to go to village Y to talk about cholera and how to prevent cholera, wash hands and blah, blah. About NCDs, I mean, blood pressure, then the upcoming diseases. They will bring also motorbikes that will be used in certain clusters. Every cluster could have a motorbike. And then there will be also a supervisory vehicle used by the manager to go around and make sure the whole community health service is strengthened. Once we're able to do that, it is said that if you actually have a well-functioning community health service, you could take care of 70 to 80% of your diseases. So this is where the focus is, and counties are either engaging agencies like Living Goods, like 5-6 counties are already going in that direction with Living Goods. Others are using AMREF, and others are using Farm Access.
Right.
And these groups actually add technology and also support and partner with counties to make sure that that community health service is markedly improved.
All right,
Yeah.
Fair enough. We're going to take one more question from the audience, then I'll come back here so that you can have your closing thoughts so that we take this home. Mashirima.
Just before that question, Joe, the governor has talked about primary health care, and there's an issue that came out when I was at Kipsing about hygiene. How do we depend on the health centers, yet the residents don't have water for personal hygiene? Perhaps he could answer that question.
Okay. Do you want to do that? He can do that as part of his closing comment.
There's Letitia. Letitia had a question on maternal health care. Letitia? Naam, Letitia nadhani ni mwanafunzi wa KMTC, na hili ni swala ambalo limekugusa.
Okay, I'm Letitia Omolo. My question goes to the government, to the governor. I was asking her on or what your measures on high cost of medical services. Thank you.
Joe?
All right, so the high cost, and I think there was something raised about maternal health. This county still has some of the grimmest statistics about that. 700 plus 790 actually per 100,000, and infant mortality over 120, I think. That's pretty high, so you can address that as you close, but I want to start from that end. Dr. Abubakar, your final thoughts on universal healthcare, where Isiolo County is, and what we can look forward in the next couple of weeks, months to come, and this is in 30 seconds.
Thank you, Joe. Isiolo County is ready for UHC. We have strengthened our healthcare systems. We have strengthened our commodities and supplies, the referral system. We're improving the human resource. And so, in short, I can say we are ready. But as a last point, I would like to say that every day, Isiolo people, Kenyan people, have people who have to make decision between death and poverty. UHC is here to sort that. So let's walk the talk on UHC.
All right, Valentine.
Yes.
Your closing thoughts.
I think, universal health care for women and children who are extremely affected when it comes to health issues is very important, because when you listen to our maternal rates are very high. Our infant maternal rates are also very high. So if we're going to work hand in hand with government, our civil society, to help address these issues, we are going to go a long way in achieving universal health care. Because when the women and children are sick, the men are also sick, the economy is sick. So my thought would be, it is important for civil society and for government to look for working ground to ensure that we achieve universal health care.
Mr. Moredi.
Good. Universal health coverage is like Tusker. Has no equal, makes us equal. So we are ready to serve all Kenyans equally. We'll continue procuring quality, affordable, safe commodities for all Kenyans. And we work with strategic partners, we work with the Council of Governors, we work with the county pharmacists, we work with the faith-based, we work with institutions supporting PWDs to ensure that all those who are disadvantaged also enjoy universal health coverage. And KEMSA is ready for that.
Thank you. Bwana Governor.
I would like to say that my director has actually put very briefly and very clearly the various steps that we have put in place on issues of human resource, medicine and medical commodities, infrastructure, where already we now have 2 theaters other than, we had only 1 theater at Isiolo. Now we have 3 theaters that are operational. We have operationalized Garbatula, we have operationalized Merti. That means we are bringing services much closer to people so that we are able to reduce that distance. We want to focus now on strengthening community health service. I want Isiolo people to really understand community health service is our way to go because of the distances. You have heard we have to travel an average of 49 kilometers between the facilities. That gap can only be breached if we have communities serving communities at the places they are. Therefore, we need to strengthen that community health service. We need to put technology in the hands of the community health volunteers. That way, we will reduce this maternal mortality, we will reduce this infant mortality, we will do health education so that health behaviors are created within the people so that we minimize the diseases. As concerns the cost of healthcare, universal healthcare is geared towards making sure that a patient walks in, gets quality care and walks out without paying if possible.
All right, thank you very much. And as Dr. Abdullahi said, Dr. Abubakar said, it is a journey, and that journey also continues for us on Monday's special town hall that we are going to be in a different county next week. I want to thank my guests very, very much. Dr. Mohamed Abdi Kuti, Governor of Isiolo County, Eliud Moredi, Commercial Director, KEMSA. We also had Valentine Nyagodhie, who is from Pastoralist Gender Initiatives, and last but not least, Dr. Hussein Abubakar, who is the County Director of Health. Tuaenda pi wiki ijayo Mashirima.
Nadhani tutakuwa tunaelekea katika maeneo ya kati mwa nchi, lakini itabidi uzidi kutegea Citizen TV ili uweze kujua tunaelekea wapi. Tukiwa tunajadili swala hilo la afya. Nadhani hii leo wananchi ambao wamekuwa hapa wameweza kuuliza maswali na wakapata majibu. Mlipata majibu? Mmefurahia kuwa mmepata majibu? Kama kuna maswali mengine nadhani itabidi mumpate gavana akiwa pale nje pamoja na maafisa wa KEMSA ili uweze kupata yale majibu ambayo labda hatukuweza kuwa na muda wa kuweza kuuliza maswali hayo. Lakini kutoka kwangu mimi ni Mashirima Kapombe na kutakia usiku mwema.